Learn about the status epilepticus. Hello everyone, myself is Dr. Archana, intensivist. I'm working in the ICU. So first we'll see the what is the definition of status epilepticus. So basically status epilepticus is the neurological emergency in which the seizure will persist more than 5 minutes or patient will have the recurrent repeated seizure. In between the patient will not regain the consciousness. So that is the status epilepticus. One more definition we have is the, what is the so patient will have the generalized tonic-clonic seizure more than 5 minutes or focal seizure with impaired awareness more than 10 minutes is considered at the status epilepticus. So what is the common causes for a status epilepticus? It could be the metabolic that includes the hypoglycemia, electrolyte imbalance and hypernatremia. In case of liver failure, hyperammonemia, then intracranial pathology, stroke, intracranial bleed, death, then drug and toxics that include sometimes the alcohol withdrawal can cause the seizure or status epilepticus. So infection could be the cause like the encephalitis, autoimmune, and poor medication adherence can be also cause the status of the patient. So what is the clinical sign and symptom? So first the patient will have the continuous convulsion. It means the patient will have the GTCS, generalized tonic-clonic movement persist. Then patient can be present to you with the loss of consciousness, altered mental status, confusion. Then patient can have the muscle rigidity, repeated jerky movements. Sometimes urinary and fecal incontinence can also be seen. Patient can have the excessive salivation. And patient will present to you in the post-ictal confusion or unresponsive. So what is the investigations required? If your patient is already admitted and having the bedside, so first you do the blood glucose. So you rule out the hypoglycemia. So hypoglycemia can also cause the seizure. Next you do the ABG. In ABG, if you are getting the acidosis, yeah, hypoxia, that could be the cause for the seizure. Next is the EEG and vital monitoring. Then you do the blood investigation. You send all the electrolytes like sodium, potassium, calcium, magnesium. Then do the CBC, RFT, LFT, and serum ammonia also. That will rule out the liver disease. Then sometimes if patient is already taking the anti-epileptic drugs, so patient is not already on anti-epileptic drug, we have to send the level of anti-epileptic drugs. Sometimes we have to do the toxicological screening if we are not getting the clear history. So patient overdose, drug overdose, toxin exposure can cause the status. Then we do the neuroimaging and infection workup. Neuroimaging, we have to do the CT brain urgent. If you are getting the CT brain done and if you see the hemorrhage, that could be the cause for the status stroke or mass lesion, we can rule out. Then if we have time settled all the patient, then we can go for the MRI of the brain. We can also do the lumbar puncture and see the CSF analysis. Since the meningitis encephalitis could be the cause for the status epilepticus, in CSF analysis, we can rule out the meningitis and encephalitis. Then if your patient is, if you are suspecting sepsis, then you can send the blood culture. Then neurological monitoring, what we have to do the electroencephalography that detects the ongoing seizure activity and required for the non-convulsing status epilepticus. And if your patient is admitted in the ICU, we have to do the continuous EEG monitoring. Then coming on to the management and treatment of the status epilepticus. First is the initial stabilization. So we have to manage the patient with the airway breathing and circulation. Then if your patient is having hypoxia, we can give the oxygen. We have to take the IV access and check the blood glucose and correct the metabolic abnormality what patient is presenting. Then we can do treat with the first line anti-epileptic drug. We can give the lorazepam, diazepam, midazolam. So this is the rapid acting short choice, first choice of the drug. So we have to give first this. Second line anti-epileptic drug could be the Livera, then valproic acid, fosmanitol, or phenytoin. Stat trial said that these all three medication has the same efficacy. So whatever we have available with that, we can give it. Next, third line. If your patient is refractory status epilepticus, then what we have to do? We have to shove that patient in the ICU and we have to intubate and mechanically ventilate them. Then we can start the after ventilation, after intubation, we can start then the phenobarbital infusion, propofol infusion, and midazolam infusion. If we are not able to control with the all three above infusion, the new guideline says that we can start the ketamine infusion. So what monitoring we do is that we monitor the continuous easy monitoring and maintain the seizure control at least for 24 to 48 hours. Then if you have already given this on anesthetic drug and ventilating your patient under the EEG guidance, slowly we can wean and extubate them. So sometimes the patient has the status, so complication like brain injury, hypoxia, metabolic acidosis, cardiac arrhythmia, and death. Sometimes patient can have all these complications. If you have any question, write in the comment box and subscribe my channel for the all this knowledge. Thank you.